Well, thank you. Well, the initial scheduled talk did very well fit into the live case shown by Miguel Montero Becker. So I'm now giving you an overview about the background of the use of atherectomy below the knee. So plain balloon angioplasty is still the standard of care below the knee. However, already shown by the group from Leipzig is basically that restenosis with conventional balloon angioplasty at 3 months based on angiography in this study from 2010 was almost 70%. So this was probably the time of, let's say, imperfect application of balloon angioplasty, short inflations, probably low pressures and small balloons. So how to properly perform PTA today is described over here. It's proper vessel sizing, IVUS may play a role, or external ultrasound, and the time of balloon inflation should be sufficient, and in particular avoiding dissection means slow increase of the balloon pressure over time. And if you look into the outcome of the Saval study recently published with the opposite outcome of the experience of the Leipzig group published a couple of years ago, you can see over here with appropriate balloon or POBA strategy, you can even achieve a primary patency of more than 70% with regular balloon angioplasty. However, there are the well-known limitations of balloon angioplasty as shown over here. This is a lesion that had been treated with orbital atherectomy, meaning with vessel preparation. This is a lesion which was directly or underwent direct balloon angioplasty, and the result was the dissection, whereas in the lower part which underwent vessel preparation, there was no dissection. And this is the overview about the different kinds of atherectomy devices for below the knee application. Most frequently used devices are orbital atherectomy or the rotablator, where orbital atherectomy is not available, and in some proximal lesions, directional atherectomy. In my hands, high-speed rotational atherectomy, you can also use the term sending, is mainly indicated in severely calcified lesions. This was a case of a TPT subtotal occlusion. I was able to cross with a guide wire, but I couldn't even engage this kind of lesion with the lowest profile coronary balloon. However, with rotablator, we could achieve a very nice lumen followed by balloon angioplasty. So what do we know about the outcome of atherectomy? Unfortunately, we have not that much published evidence, at least no level 1 evidence so far. This is a retrospective matched analysis of the YQI database, including in total almost 3,000 lesions that had been treated either with atherectomy or plain balloon angioplasty. What you can see over here is there was virtually no difference in different acute and longer term outcomes. So there was no benefit for atherectomy overall. However, there had been some particular devices showing better outcomes as compared to plain balloon angioplasty. If you look on major limb amputation, laser did not perform as good as POBA. The other devices had been similar effective as compared to POBA. If you look on primary patency at 1 year, directional atherectomy was the only tool showing better primary patency, which is also translated into a reduced target vessel revascularization rate. If we compare the different atherectomy devices, including orbital atherectomy, excisional atherectomy, and laser atherectomy, again, it seems that there is a benefit, at least a trend, towards better outcome for excisional atherectomy as compared to laser and orbital atherectomy for different outcomes, including procedural acute outcomes and 1-year outcomes, including patency and re-intervention rate. So I told you there is almost no level 1 evidence. There are 2 randomized controlled studies, but these are more or less proof of concept studies, definitely underpowered, including the ADCAT study, which was comparing directional atherectomy followed by DCB angioplasty, unfortunately using the Lutonix balloon, as compared to POBA followed by the Lutonix balloon in lesions ranging from 6 to 25 centimeters in length, and this is the primary outcome based on angiography. You can see over here there was a trend towards better patency for the atherectomy approach, and also a trend towards lower re-intervention rates, but based on the small number of patients enrolled, there was no significant difference in those endpoints. If you look on combined endpoints, death and amputation-free survival, there was a benefit for the combination of DA and DCB. It was almost significant. There was a trend for a better event-free survival. Overall, less events if directional atherectomy was performed as vessel preparation before DCB. The optimized trial was a very similar study, also obviously underpowered, evaluating the value of orbital atherectomy followed by DCB versus plain balloon angioplasty plus DCB in below-the-knee interventions. Again, if you look on patency at 6 months, there was a benefit, even not significant based on the small numbers available for angiographic follow-up. However, there are some hints that at least patency benefits can be seen if a vessel preparation with atherectomy is performed. However, if we look on major adverse events at 1 year, no benefit for the combination of atherectomy plus DCB. So in conclusion, we have very limited evidence for atherectomy in BTK lesions. Directional atherectomy may result in benefits regarding primary patency and freedom from TLR. However, worth to mention that directional atherectomy usually is applied in larger vessels. Therefore, these lesions usually have a better distal outflow, and that may result in this better outcome as compared to the other atherectomy technologies. The ADCAT and optimized trials have been underpowered, but may be worth to repeat these studies with an effective DCB. So the favorable patency trends have to be shown to be also clinically beneficial in the future. So what is my algorithm? If we have no or moderate calcification and a focal lesion, directional atherectomy plus DCB, it's available in Germany, is my strategy, or a drug-eluting stent. If we are dealing with long lesions, I prepare the vessel with balloon angioplasty followed by DCB or a specialty balloon. In calcified lesions, orbital atherectomy is, in my opinion, the best way to perform. Lithoplasty can be an alternative tool, and in long lesions, definitely orbital atherectomy, depending on the outflow. As mentioned, if we are treating patients with impaired pedal outflow, then I never use orbital atherectomy or DCB. Thank you very much.